Hi, I'm Stephanie Shelton, and this is Conversations on Health, How We Get There, episode 21. How many times have we all asked, when will they find a cure for cancer? But we know, of course, that there's no one cure any more than there's just one type of cancer. Each one requires its own research pathway. But there have been great strides in recent years. Some cancers which used to be a death sentence are now either curable or able to be treated as chronic illnesses. So my guest for this episode is Dr. Theodore Lawrence. He's a professor of radiation oncology at the University of Michigan and has an active oncology medical practice. He's also researching better treatment outcomes for gastrointestinal and central nervous system cancers. His research continues to be supported by the National Cancer Institute. I've known Ted for a very long time, since he was still a medical student and he was just married to my second cousin. He's always been really excited about his work, and he has that rare ability to explain really complicated concepts in a way that we can all clearly understand. You'll see how much he cares about what he's doing and discovering. He made me feel very hopeful about a disease which never used to be described with that word. I think you'll feel the same way. It's a really long interview, but honestly, it's worth every single fascinating moment. Thanks for coming on the podcast, Ted. This is really cool.
It is. I'm excited to be with you today.
So I kind of would like to start at the beginning for people who don't really know too much about cancer and radiation and chemo and how they all kind of can work together. You've been involved with radiation cancer therapy for most of your career. And most patients, me included, think of chemo. You don't think of a drug as chemo. You think of drugs as this pill you take. And then you think of chemo as chemo, those drugs that drip. And radiation is separate. And they're all separate processes that you may or may not have to go through together or one after another. How does what you do work?
The oncology team is actually composed of 5 different kinds of physicians. The ones that you see who are, say, patient forward would be surgeons. And I think everyone knows what a surgeon is. A surgeon removes tumors in the case of oncology. Then there's radiation oncology, there's medical oncology. There's also the pathologist and the radiologist.
Oh, yeah.
They're most critical members of the team, even though you don't necessarily see them when you're in the clinic. So radiation oncology is actually very much more like surgery than it is like chemotherapy or medical oncology. I'll talk about medical oncology in a moment. Radiation is very much focused on a localized area, and it uses beams of high energy that can be focused directly on a tumor. So radiation oncology comes into play in many settings, from small tumors that can be cured, and the one that I'm thinking of right now, for instance, is larynx cancer. In the case of larynx cancer, the voice box. It used to be that almost everyone had to have their voice box removed by a surgeon. And of course, you would lose your speech. Radiation therapy can cure that tumor and preserve speech.
Wow.
So it's very like surgery in that it's localized, but of course doesn't involve cutting people. It involves using these very highly focused.
So you're that targeted, because I do remember the day when if you went to radiation therapy, it burnt everything around the tumor.
That was many, many years ago. Now there are techniques, and since I entered this field in the late 80s, so I've seen a tremendous amount of technical progress. But the technical progress has been focused mainly on how do you focus the treatment more and more on the area that needs to be treated and less on the normal tissues. And so radiation therapy in many circumstances has very little toxicity, even though I'm sorry to say, many people still think of the old version in which there was much more toxicity. I'll talk more about radiation therapy in a moment, but just to complete the picture, the medical oncologist is typically concerned with systemic disease. What I mean by that is disease that's in many parts of the body. Treatments they're focused on can be a pill, can be an infusion or something that's injected into the vein and circulates throughout the body. But their emphasis is mostly on disease that spread throughout the body. So the surgeon is very much focused on only on localized disease. The medical oncologist very much on diseases around the body. Radiation oncologists can focus on both. So we may focus on the larynx cancer example I just gave you, or sometimes if somebody has 3 or 4 areas that are spread throughout the body, we can use very targeted radiation to get rid of all those spots. And the newer evidence is showing that can make people live longer when it's done in the right setting.
Wow, that is really heartening. It's the difference, I think, between beyond dreading having to have some of these things, and not that you're going to look forward to it, but that you can kind of look through it to the outcome.
Exactly. At the same time, medications that are used more by medical oncologists than by radiation oncologists, but medications that block the side effects of treatment have also developed dramatically over the last 10 or 20 years. So that combination in our field of greater ability to target the tumor and greater ability to give medications that might overcome side effects has made the field so much more effective and so much less toxic than it used to be what people are thinking of from, say, 10 or 20 years ago.
And yet we still talk about, quote, a cure for cancer. And why haven't we found it yet? And I was interviewing a physician many years ago who said to me, we haven't found it because it isn't cancer. It's many cancers. It's many kinds of diseases, and each one has to be targeted individually. And would you say that's essentially true?
That's exactly correct. There are, it depends on exactly how you count it, probably in the range of 200 different kinds of cancers.
Mm.
And there are some similarities between them, but there are many, many differences. And so the approaches that we use to treat them have to be individualized. They're individualized for the disease, and then different patients with the same disease need to get individualized treatments. There is no, there will not be a cure for cancer. There have been many cures for individual cancers, and we keep making progress, but step by step. It's not going to be, I don't think it's going to be, here's a magic pill and all cancers are gone. I don't see that happening.
Or like in breast cancer, which seems now, and I know there are the different types of breast cancer, but in many of them to become almost a chronic disease that you can live with.
That's exactly the goal. And so I think we talk about curing cancer, and that's always the goal. But if you can have somebody live 5 extra years of productive life that they wouldn't have had 10 or 15 years ago, that's also progress. So the average life expectancy for people with cancer has improved dramatically certainly over the last 10 to 20 years.
Let me ask you about something that's it's a word I never heard of. Radiosensitizers. You work with radiosensitizers, as well as working on targeting molecular therapies.
Right.
What is a radiosensitizer?
So radiation sensitizer is a medication that makes radiation selectively more effective against the tumor than it does against the normal tissue. And often there's some medications that are purely radiation sensitizers. That is, their only effect is to make radiation work better. But we also do a lot of work with medications that have effectiveness on their own, and they make the radiation work better. So something that just increases the effectiveness of radiation but against the tumor, but does the same thing against the normal tissue, that's not a benefit. That's just like giving more radiation. What I've been studying for a major portion of my career is how can we pick treatments that selectively make the tumor more sensitive to treatment while not making the normal tissues more sensitive. Because that's always the balance. Every treatment we have, this is for all of oncology, it's for all of medicine. Everything we do has good effects and bad effects. And we're trying to optimize the good effects while we minimize the bad effects.
If you have to look at each tumor essentially as unique in cancer, in the sense that everybody's DNA is different and we are each, many of us have alike things, but we are not alike in that respect. Doesn't this kind of make it more complicated, make things take longer, and ultimately make it almost impossible for some people who don't get regular medical care and can't go to the cancer centers to even get care?
That is a huge issue in our field. Some people have estimated that there'd be a 10 or 20% improvement in overall life expectancy if we just delivered the treatments that we already have to everybody who could use them. And that whole concept of, it's got a name of implementation science. It's a major field. It's not my area of expertise, but there's a whole group now in oncology of people who are trying to figure out ways of optimally delivering, sometimes it's the treatment, but also optimally delivering screening. It's both cancer screening and cancer treatment. There's so many people, for instance, who could have their cancer caught at an early stage or at a precancerous stage if they had screening. But if they don't seek medical care, then that can turn into a cancer that takes their life. And so, implementing what we know today would produce tremendous improvements in outcome. And that's a thorny problem that I don't have the answer to.
No, we're talking about, medical systems, healthcare systems, outreach in the community. It's very complicated, and even countries which I have profiled on this podcast with universal health care are not able to do that all the time. So extremely difficult.
Radio sensitization question, because I want to explore that just a little bit more with you. In the past, radiation, and still in the present, radiation is combined with chemotherapy. Now, chemotherapy often is targeting rapidly dividing cells. In many cases, cancer is one cell becoming two to four. That's happening more rapidly in cancer than it is in normal tissues. So a lot of the original chemotherapies are just targeting cells that grow rapidly. But if you pause for a moment and think about, what does that mean? Well, we have normal cells in the body that also divide rapidly. For instance, the linings of your intestine are being turned over every 3 days. And so those are rapidly dividing cells. That's one of the reasons that chemotherapy can give diarrhea or those sorts of side effects, because they're rapidly dividing cells. I think again, what other cells are dividing rapidly? Well, our cells that make blood cells are rapidly dividing. White blood cells, which are always ready to defend us against infection, are being rapidly made. And that's why chemotherapy can make your blood counts decrease. Those white blood cells go down, so they can't defend you as well and put you at risk.
Right.
So do use those in combination with radiation very, very effectively. For instance, the example that I gave you a few moments ago about the voice box, the larynx. Even patients who have pretty big voice box larynx tumors can be cured with combinations of radiation and chemotherapy. But then we also have the new concept over the last 10 or 15 years that you mentioned a few moments ago of molecularly targeted therapy. So the goal there is, can you pick what's making that cancer a cancer? Not just is it dividing rapidly, but is there something about that cancer? I think of cancer as a car that's out of control, as a car. So when you drive a vehicle, hopefully you use the accelerator when you use it, when you're supposed to use it, and you use the brake when you're supposed to use it. In the case of cancer, it's often like the accelerator is stuck to the floor, and that's just driving the cell, 1 cell, 2 cells, 4 cells, 8 cells. And that driving process is what gets you in trouble when it's uncontrolled. There are now medications, and I give 45-minute talks on this.
Not on this.
There are medications that, rather than just trying to make rather than just targeting rapidly dividing cells, target the accelerator that's stuck to the floor, target what's driving that cell to
Oh,
become a cancer. And that you can imagine would be much more specific than
yeah.
just targeting cells that are dividing rapidly.
Well, you know, I'm sitting here listening to you, and like everybody else in the world, I hear the word cancer and I just go into panic mode. It's the most frightening word. I think it's worse than somebody telling you that half your heart isn't working. It's just panic mode. And yet listening to you, it makes me feel so hopeful that we're already so far, and that, as you say, there's going to be so much more in the pipeline.
So I think that's you hit it exactly. One of the areas I'm very, very excited about, I'd say all oncologists are excited about, is the whole area of immunotherapy. I don't know if you've heard about
Yes,
immune,
yes. And would you explain that?
right? So immunotherapy has several different forms. The form that I've worked the most with is involved in getting your immune system to try to attack the cancer. So this has been something hoped for decades. Ever since I've been in oncology, people have said, can we get our own immune system, which is so good at fighting off infections? Why can't we get it to fight off the cancer?
Yeah.
Just the way when you get a pneumonia, it fights off the pneumonia. And a major discovery that was made, I wish I made this discovery. I didn't. It won a Nobel Prize. Was figuring out how to get the immune system to see the cancer. And the breakthrough discovery was to realize cancers are so tricky. They're just so tricky. It kind of goes back to the original question. Why is this so difficult? So why is it, take a big step back, why is it that your immune system isn't attacking you all the time? Actually, there's some diseases where that occurs. I've heard of lupus, or rheumatoid arthritis.
Right, right.
These are in which your immune system is attacking your own system. Why doesn't that happen to everybody all the time? Well, your normal cells have kind of a handshake. And when the immune system is circling around, it puts out a hand, and your normal cells put out a hand, and they shake and they say, we're friends. Don't attack me. So cancers, these evil cancers that have on their cell surface proteins that would typically set an alarm off to the immune system, they figured out a way to put out that handshake. So,
Whoa.
no, they should get attacked. They say, I'm a friend, and the immune system goes, okay, friend, I'll leave you alone.
Wow.
So evil, right? But so clever.
Yes.
And so the discovery that was made was, can you, was developing a treatment. There tend to be a certain kind of therapy, antibody therapy. And that antibody is a kind of protein that puts a glove over that handshake. So the handshake can't occur. And now all of a sudden the immune system says, I have this foreign invader. It can see the cancer. It unveils the cancer.
Wow. That is just amazing.
And particularly in the case of melanoma, it has been just truly a miracle. I use that word carefully. But you and I haven't discussed this, but I'm also board certified in internal medicine and medical oncology. So I treated patients earlier in my career who had melanoma that had metastasized. And it was a terrible prognosis. Everybody died within a year or two. And now a significant fraction of patients who have melanoma that's throughout their body are now cured using immunotherapy. It's a miracle.
That is amazing. My husband's father and my mother both died from melanoma. One of my best friends. I mean, it's so common and so feared,
Yeah.
especially fair-skinned people, you know.
So my angle on it is we're using radiation. It turns out that radiation therapy can cause cancer cells as they're injured to express these new proteins on their cell surface that
Oh,
that reveal them even more to the immune system. So can you use radiation therapy to make this immunotherapy work even better? And that's a very, very exciting area in my field.
well, I want to talk about your current project, but before I do that, I just want to talk about one other kind of cancer, which is pancreatic cancer. You work with that, and it's even part of your new study that you're working on. It is always presented to us, the public, as a rare cancer. And yet, in my little tiny circle of friends, and I am not one of these people with a million zillion friends, at least 4 people of varying ages who were healthy, athletic people have died rather rapidly from pancreatic cancer. How can it be rare if just in my little world, so many people have had it?
Breast cancer is somehow a secret, and so many people have said the same thing to me. So it's pretty far down the list in incidence. Incidence means how often does it happen? But it's very high in the fraction of patients who die of it.
Yes.
So it's estimated that about 55 or 60,000 people a year in the United States will get pancreas cancer. Compared to lung cancer, where it's 130, 140, 150,000 people a year get lung cancer. So there's a huge difference there. But the 5-year survival rate for pancreas cancer is just barely broke 10% a few years ago. So it's an unusually lethal cancer. It's actually projected that by 2030, the early 2030s, it will be the second biggest cancer killer behind lung cancer.
Whoa. Why?
Well, the incidence has gone up slightly to some extent, but mainly it's been very difficult to increase the cure rate in pancreas cancer. Whereas in lung cancer, there have been improvements, in breast cancer, there have been improvements, in prostate cancer, there have been improvements. All these areas have improved more. Of course, prostate is only men, breast cancer is almost only women.
But
Lung
they're
cancer is most
tied to each other, right? I mean,
right, very much.
yeah.
And lung cancer is going down in the United States. Thank goodness, fewer and fewer people are smoking.
Yeah.
But with pancreas cancer, the incidence is going up and the lethality is still, I mean, when I started off in the field years ago, it was a 5 or 6% 5-year survival. I guess you can say, wow, it's 11, 12% now, so it's doubled, but it's still a horribly small number.
And yet, you still say to me it's way down the list of the number of people who get it. And yet I know so many people who got it.
And who died of it.
Yes, which I find, well, they got it first. I mean, we knew they had it, and then they died very quickly. But and that part to me is just amazing.
So pancreas cancer has several aspects that just make it so lethal. First of all, it's driven by a defect in its DNA that makes it unusually resistant to treatment. That's part one.
Mm.
Two is, for reasons we don't understand, it tends to make scar tissue around it. And so it makes it difficult for medications to get into it because it's protected by this scar tissue. The other problem with the scar tissue is it seems to keep out those immune cells that I was telling you about that could attack it. So immunotherapy has been completely ineffective for pancreas cancer because of that scarring. So it's at least those 3 issues that have made it so difficult to treat. That's why one of our projects in this grant that I've just gotten from the National Cancer Institute is trying to turn pancreas cancer into what we call a cold tumor. Cold meaning there aren't any immune cells that get in, into a hot tumor, meaning can we make it immunologically hot so those immunotherapy cells can get in there and kill it.
All right. So tell me, you're the principal investigator of this new government-funded study, which targets pancreatic cancer among these others that you're working on. Tell me what you're doing.
So the big picture of what we're doing is we're trying to overcome resistance to radiation therapy. Even though radiation therapy is very effective in many settings, both, as I said, for that small cancer of the larynx, the voice box, or sometimes someone has a large tumor in the abdomen, or they have pain in a bone because of cancer, and radiation therapy is very effective in many of those settings. There's still so much to do. So we're looking at what makes cancer resistant to radiation. One major area is in having cancers not be sensitive to immunotherapy, just as I was mentioning in pancreas cancer. So in this grant we got from the National Cancer Institute, the focus of that part of the project is how can we make pancreas cancer be visible to the immune system, just like melanoma. Mm-hmm. And that's being done with both radiation and with drugs that make cancer cells more sensitive to radiation. I can give you more details, but at a big picture, that's that project. The second project is in brain cancer. High grade, we call them high grade gliomas or glioblastoma. It's a terrible, terrible brain tumor. And I'm sure you probably know that Ted Kennedy died of this. John McCain died of this kind of cancer. And George Gershwin died of this at a very young age in his 30s. And this is another one of those cancers. It's like pancreas cancer. It's been tremendously resistant to treatment. And it's resistant. One mechanism of resistance is that it is very effective in reacting to radiation and repairing the damage to DNA. We sort of skip that step, but radiation works by damaging the DNA, the blueprint of the cell. So when the cancer cell tries to go from one cell to two, both of those cells die. Cancer cells are specifically glioblastoma cells, these brain cancer cells, are very good at repairing that damage that radiation puts into them. And they do it because they have a special kind of metabolism. They use their energy to make more glioblastoma cells. Your brain cells use more energy to help you think, to communicate with each other, to do all the things that you do to make you human. But the brain tumor cells say, we don't need any of that. They hijack all the mechanisms and use them all to just grow more cells and to repair themselves from any damage that we put in from treatment. So one of our projects is how to counteract that metabolic process that the brain tumor cells have and counteract that so they can't repair that damage and so we can kill them. And then the third project is in breast cancer. And even though there have been huge advances made in breast cancer, there are still many women who die of breast cancer. And so we are trying to help women who have advanced breast cancer. I'm going to say locally advanced breast cancer. That means it hasn't spread to the rest of their body, but it's going to give them terrible trouble where it occurred, or it could spread. And there we're working specifically on how do we make it harder for the breast cancer cell to repair their DNA damage that radiation gives them. So there are specific drugs that we're working with that block the repair of DNA damage in these breast cancer cells. All three of these now have launched into clinical trials, all three of these projects.
So you started with, I think you described it as FDA approved drugs.
That was a strategy that we decided to take. And a lot of people, and there's a lot of terrific work going on in developing brand new agents, and we should talk about that. But in the context of this application, I wanted something that could get to patients within a few years. So we decided to try to pick the best FDA-approved drugs that interact with radiation so we could do laboratory work to optimize them in the lab and then bring them into the clinic within a 5-year period.
So you got a government grant for this, and it's not just you and your team. It's a number of medical focusing universities and teams within the country. How does this work? Who pays for it? And ultimately, once it gets through those trials, which I assume are paid for by the grant, how does it get marketed or produced by a drug company and then marketed? How does that work?
And so you've asked a really key question, and it's a multi-step process, and some of it occurs in the universities, places like ours, University of Michigan, and others occurs outside within the drug company realm. And it's important to understand that most of the university work is in what we call target discovery. That is, can we find that medication? Can we find that approach that would unstick the accelerator from the floor?
Right.
So that's called typically target discovery.
Yeah.
And that can be a multi-year process in which you begin by understanding the biology of the cancer cell. You understand why is that accelerator stuck to the floor? And then begin to develop a drug, or I'll call it a drug-like molecule, that will interfere with that process. And that's typically, or I would say often funded, maybe even usually funded by government grants or by foundation grants. Then there's the stage in which that drug-like molecule needs to be turned into something that could actually be put in a patient.
Mm-hmm.
There's an expression that we use in our field. It's called the valley of death. Yeah, I know it's a terrible expression, isn't it? But
Yes.
it's how do you get from that cool idea and the drug-like molecule to something that could actually be put safely into a patient? So first of all, you have to go through a process of testing hundreds of drugs, hundreds of drug-like molecules to optimize the effect you're looking at. And that often is hard to do within a university setting because now we're getting into major expense. Then once you have something that looks interesting, you need to test it in multiple animal models. So sometimes we get it in mice and rats, but then often it needs to be tested in animals that are more like us, like dogs or monkeys. That gets to be very expensive. And often these you need several $1,000,000 just to move one drug to the point of doing what we call tox testing, toxicity analysis. So now you've made it through that stage. We're now talking about sort of the valley of death here, where the drug company either decides to pick this up from you or not. So a lot of this work is being done by us with our grants, and we're hoping that somebody picks it up who has serious money to move it ahead. Now, let's say you finally have something that looks interesting. Now it goes through 3 phases of trials.
Right.
Phase 1, phase 2, and not surprisingly, phase 3. So phase 1 is just asking, what's the safe dose to give to somebody? And we hope many phase 1 trials actually do produce a response in patients. But that's not the purpose of the phase 1 trial. The purpose of the phase 1 trial is what's a dose that you can give to somebody to see if it can be effective. And that trial will cost, at least in the range of $5 million. Now you're beyond typically what a university would do, maybe even $10 or $20 million. You're going to treat enough
Typically in
patients.
a trial, because I read about it was a small trial or it was a large trial, what would that mean? What is a typical number of either animals at that point or when you get to people to test a drug?
Well, so animals, often these studies will be hundreds of mice. When
Whoa.
we get to people, the phase 1 trials are typically 20, 30, 40 people.
It's small.
And then you hope in that trial to have at least a signal that there's something good happening with that patient. And then the phase 2 trial is trying to see, does it really have some kind of effectiveness? And those studies are usually between 50 and 100 patients. And then if it really looks like it's interesting compared to what we call historical controls, that is patients who had the same disease, the same stages, you compare them historically, but there's always a risk that those patients aren't the same as the ones that you treated.
Yeah.
But the gold standard and what's required for a drug to be approved is a phase 3 trial. So this is a randomized trial. By randomized, I mean you take a whole group of patients who you think are overall very similar. They have the same disease, roughly the same stage, and you toss a coin. And if it comes up heads, they get the best standard therapy. Comes up tails, they get your new therapy. And so by doing that, you hope to compare equal groups treated at the same time of patients who are roughly the same kind of patient. Those studies are hundreds of patients, typically 300, 400, 500, sometimes as many as 1,000 patients. And those studies cost tens of millions of dollars to run.
And those are the ones the drug companies have to pay for.
You have to pay for, and I mean, a very interesting occurrence has happened since I was young compared to today. So when I was young, the companies would typically take their interesting drugs and give them to the National Cancer Institute and say, you choose which studies, the most interesting studies, will help us to move the drugs ahead. And now in the last 10 or 20 years, it's mainly been the drug companies are designing the studies and the physicians at the universities and other places are running them. So pharma is controlling a lot of the development now, and that has good sides and bad sides. They have the money.
That's
They
what
have
I was
the
going to
ability
say.
to do it.
Is it good or bad? Because I have heard many times that the drug companies, the big ones that actually have the money, don't even want to undertake these trials unless there's something sure that they can charge a lot of money for, that's going to come out at the end because of the expense of the trials themselves.
Right. And different people figure this in different ways. The drug companies will often say it takes $1 billion with a B to bring a drug from concept to market. And that might be true. And there are medications that go all the way through, even to phase 2, and then they run a multi $10 million phase 3 trial, and it didn't work.
Yeah.
Why does that happen? How does this happen? It's there's so many reasons, and part of it is that cancer is very tricky. Part of it is we do our best in the laboratory, but mice are not people, and things that work in mice sometimes just don't work in people. It is I'm going to call it almost a tortured process that can take, on the quickest is a decade, and
Yeah.
typically it's 15 to 20 years
Wow.
between concept to FDA approval.
All right. So just to get down to what most of us see, at the end of all of this, we see an FDA approved procedure or drug or whatever, and we see an enormous price tag on that. And we see that some insurance companies will pay for it or pay for part of it, and many won't. Like the discussion we're now having over the weight loss drugs, the Wegovy's, um, and I think perhaps you saw the study that was done on Ozempic by Yale and a couple of other top-notch operators, that you can make Ozempic for under $5, and yet it's $1,000 a month that the drug company is charging the insurance companies. So, it comes down to what is real, what is fair. A company has a right to make a decent profit. The government used to be involved, I think, as you suggested, at a lower level for longer with their money. That's our money, of course. So in that sense, we're paying for it, but differently. How should it be? I mean, is it fair that yes, a drug company puts all that money into it, and then they charge so much money that nobody can afford to have it?
Yeah, well, you're asking me a very, very hard question, and
I
a lot
want
of
you, you
very
know,
smart
to
people have
be
thought about it.
Solomon and make the decision.
Yeah, I think that I think you summarized it well. The drug companies should get a reasonable rate of return, but there really is no market. You have a new medication, especially before it goes off patent or when you're first to market for something that's treating a very difficult disease. And these immunotherapies are a good example. So what's a fair rate of return? Now, the way the British approach this is they look at something called, it's quality, they're called QALYs, quality adjusted life years.
Huh.
What that means is they judge how much longer will people live with this medication. What is the quality of life during that amount of time they're living? And you can calculate a QALY. So if you have a perfect life for a year, that's a QALY of 1. If you
Yeah.
have a life that's pretty bad for a year, that's a QALY of a half. And so they set a certain spot, a certain $100,000 for quality adjusted life year. And that's what they're willing to pay. If the drug company has a very expensive drug that only prolongs life by a couple of months, they'll say the national health insurance will not pay for that drug at that price because it doesn't meet our standard of quality adjusted life years. So this is one of those issues on a societal basis. I don't think we should be paying huge amounts of money for a drug that's going to prolong life for 2 months. But if it's my life,
Yeah.
now I'm interested.
Yeah.
So it's a very difficult problem. I don't think we can continue to do what we're doing. We can't spend, I don't see how we can continue to spend 18, 19, 20% of the gross national product of the United States on healthcare. I just don't see how we can continue to do that. So we have to have some way to rein in the cause.
All right. So other than what we've talked about, and that in itself is really exciting, what else do you see ahead for cancer particularly?
I see continued improvements. I think that there's a technology side that I'm involved in which we're able to see tumors better, to see smaller amounts of tumor more accurately, so we can target them. Better ways of delivering radiation therapy, for instance, in my case, or other forms of therapy. There's continuing discovery of new targets, of new ways of finding out what's the Achilles heel of cancer. Everyone's very excited about artificial intelligence. AI has been a big boon to our field.
Yeah,
Just
we didn't talk about that. What do you envision for it? What are you already using it for?
so there's so many aspects of it. Again, I don't feel like a great expert in AI, but in some of the work that I've done in drug discovery, it used to be that you had to physically make a lot of these drugs I was talking about. You have to make 100 potential variations of a drug that was interesting and then physically test each of them out. Now, with AI and other improvements in software, one can do a lot of work in what's called in silico. You can do this work in the computer,
Uh-huh.
and the computer can calculate what's the shape of that target and what's the shape of your drug, and is your drug going to fit in that target, and run through thousands of combinations and need to make only a relatively small number of drugs, and that number is going to be so much closer to the finish line than you would have been by making hundreds physically. So that is a huge area that's improving things.
And keeping costs down.
Keeping costs down, absolutely. In my case, there's a lot of work that we do in which we have to tell the computer, avoid this,
Uh-huh.
make sure you don't get involved in that, and we have to physically enter that into the computer to tell it. And AI can say, I know what a liver looks like, and pop that right into the computer. And so that will save us a lot of work. Also, AI can look back at the last 1,000 patients we treated who had that problem. And we designed a treatment plan, for instance, and it can say, this treatment plan is better, the same, or worse than the 1,000 that before, and can present us with that information. So you can get a learning loop. You can treat a patient, learn from that patient, feed that information back into your next patient in a smooth way that will let us really take advantage of all the information that's out there, rather than have everything be what I remember or what I read about. And there's so many other examples where we can use big data with AI to learn so much more quickly than we have in the past.
Well, I could sit here and talk for another hour with you, and having come into this knowing virtually nothing and walking away like I feel like a student at a very understandable lecture. It's been absolutely great talking to you, and you've explained things so well, and I think other people are going to get excited over this. And I think what you do is you give people hope. And sometimes we don't have any hope over cancer.
But I just like to leave people with that final thought that cancer is not a death sentence. So many people are cured right now. And people who aren't cured often can live many years of productive life, even though they have a diagnosis that in the end is going to take them. And even if somebody is not going to survive from their cancer, we can do so much now to alleviate symptoms and give them so much more productive time. It's I'm so excited about the field. There's never been a better time to be involved in the cancer field and to have the opportunity to develop new treatments to help people live longer and better lives.
I can tell how excited you are because it comes across, even though you must have explained these things a zillion times, you're still excited about it,
I am. I really
which
am.
is really great. Ted, thank you. I really appreciate you taking the time to come on the podcast today.
It's been a pleasure.
Dr. Theodore Lawrence is a professor of radiation oncology at the University of Michigan and has an active oncology medical practice. He's also researching better treatment outcomes for gastrointestinal and central nervous system cancer. And his research continues to be supported by the National Cancer Institute. Among his many awards is his election to the National Academy of Medicine. You probably know that we have a crisis of youthful mental illness and suicide in the United States, and really, we're not alone. Children and adolescents in many countries are struggling with the post-COVID realities of school, social media, and expectations. For our next episode, episode 22, we're going to go back to the United Kingdom, Wales to be exact, and I'll be talking to a practicing psychoanalyst, administrator, and educator, Dr. Amani Hassan. We'll talk a little bit about all the continuing problems doctors and patients are having with the NHS, the National Health Service, and then delve into the whys and hows of mental health issues and care for young people. Are the issues the same in the UK as they are here in the United States? And do the many practitioner shortages in the NHS affect a struggling child or adolescent's ability to get immediate help? I schedule one new podcast a month, so look for the next episode in June. The drop day is usually the third Tuesday of the month. Updates on my show notes on my podcast page. I'd really appreciate it if you'd subscribe and, of course, share. We're on Apple, YouTube Music, Spotify, TuneIn, Amazon Music, iHeart, Podchaser, and my host platform, the Podbeam app. The video version is on YouTube. Show notes and links on my website, www.stephanieshelton.com/conversations. If you like the podcast, please leave us a review or give us a rating wherever you get your podcasts. And I'm Stephanie Shelton. And until I see you again, please take care of yourself and all those you love. Conversations on Health, How We Get There is produced and edited by Frank Harold. Research assistance from Dr. Richard Saltman, Professor Emeritus of Health Policy and Management, Rollins School of Public Health at Emory University in Atlanta.